Okay, this is the last chapter in Unit 5 for pharmacology and drug therapy for psychiatric problems. There are situational causes for depression and biological causes for depression. And I will let you read those. I think you can understand that. That's from a different textbook, but I think that won't be any problem for you. Depression, of course, is persistent feelings of sadness, despair, loss of energy, difficulty dealing with normal life. And you can have major depression. You can have depression that goes into a manic phase, different kinds of depression, and very disrupting to yourself and your family, and that can cause dysrhythmias, dysthymia, and that's moods that are persistently low with depression, and certainly can disrupt the family. You can have a bipolar disorder. That's where you're manic and then you're depressive. And you can certainly, it can progress to feelings of suicide, feelings of hopelessness. It's just a sad disease, and many patients and people in today's world are affected by that because we're under such stress, and you all know that, but you're under such stress, and you have family issues and health issues and financial issues, and we're so ingrained that we have to succeed, and things are so expensive nowadays. There's just a lot of reasons that we can have depression. There are two kinds of drugs. I can take SSRIs, and there's fewer side effects with those, and it increases the amount of serotonin in the brain, and it's selective, so it inhibits the reuptake of serotonin. And then tricyclic antidepressants inhibit the reuptake of the neurotransmitters norepinephrine, dopamine, and serotonin by the nerve cells. So I think tricyclic probably are some of the more popular ones that are given. You can read about the causes of depression, but I want you to make sure you know these drugs, and they're listed on page 436. Celexa, Prozac, Lexapro, Paxil, Zoloft, all of those are SSRIs, and they all have different kind of dosages here. And then the TCAs, Elavil, Norpremin. I'm trying to look at the Pamelor. That's a very popular one. Those are the TCAs. And then they have other ones that are serotonin and norepinephrine reuptake inhibitors, Cymbalta, Effexor. You hear about those on advertisements all the time. And then Wellbutrin and Desirel. Deziril's an old combined one that used to be used. I don't hear about Desirel very much. Trazodone. That's the word that they call it now. Trazodone. That's Desirel. And Trazodone, I see nowadays given to patients who have sundowner syndrome. So a lot of older patients do well on Trazodone or Desirel, and they used to give them I can't think right now. Oh gosh, I can't think of the med, but for years we used to give a patient a different kind of med. I can't think of the name, and it actually would make it worse. They would get with sundowner syndrome, they get, when the sun starts going down, they start getting really confused, sometimes combative, angry, and we'd give them this medicine, and then it would get worse. So now we see that they give them this Desirel or Trazodone. Make sure you know that, because you probably are going to see something like that. I'll think of the other med here in just a minute. But that's what this chart here is about, SSRIs. And again, here's the list of them: Prozac, Paxil, Zoloft, very common. Here's the side effects. They do not need to take. Be sure you know about serotonin syndrome, and that's a bad adverse effect, and it occurs when the level gets way too high, and they get anxious, very agitated, sweat, confused, tremors, rapid heart rate, etc. But they don't need also. So you need to know serotonin syndrome, where you really need to watch for that. Avoid St. John's wort, and most drugs are taken for depression 2 to 8 weeks before they even start feeling the effects. So your patient may say, I don't feel any better. And you say, well, it takes really 2 to 8 weeks for these to kind of kick in and help you feel better. Certainly other adverse effects can be heart dysrhythmias. Those are listed all there on page 437. I need to know those. Tricyclic antidepressants, they inhibit, I told you, both the reuptake of neurotransmitters and norepinephrine and serotonin and dopamine by the nerve cells. So they help block some of that that is causing that depression, that serotonin. And those are Elavil, and that's kind of the most common one that I hear of is Elavil. Here's the side effects. Certainly if they're being depressed and you're giving them something to help with that, it can often make them very lethargic, sedated, drowsiness, fatigue, blurred vision, etc. And then they can also have some ventricular dysrhythmias or asystole. So you need to really watch for that. And they don't need to be smoking anyway, but especially if they're taking these drugs. Wellbutrin, and Cymbalta, I told you about that, and Deserel. So you need to know all of these. And as I said, they can all lead to neutropenia, decrease of white blood cells. The MAOIs, you'll see that on many drug labels. If you're taking an MAOI, you don't need to be taking that drug. So that is an antidepressant drug, but it can cause all kinds of problems with toxicity. Nardil is the most common one. Do not use the SSRIs and TCAs for at least 14 days after discontinuing an MAOI. In other words, you need to get off that, stay off of it for 14 days if they're moving you to one of these other groups. Can cause this serotonin syndrome, which we talked about, and that is life-threatening. And MAOIs can interfere with many over-the-counter meds. So you need to know that. And when you see that now, you will know it can cause a hypertensive crisis and seizure, coma, and death. So a very big time antidepressant drug. Instruct your patient to not stop taking their med without speaking with their doctor. And if they have any thoughts of suicide, they need to let somebody know. As far as teaching also, you can, they usually start on a low dose and titrate up, but nothing really cures depression. It's just a long cure, and meds can control symptoms but not cure it. We talked about the 1 to 8 weeks. Take the meds even when feeling well. Discontinue them gradually. Rinse your mouth and good oral hygiene. If taking an SSRI, take the dose in the morning, once a day in the morning or in the evening. If taking Wellbutrin, pay attention to the dosing and swallow it whole. If taking that MAOI and transitioning, do not take it. We told you that for 14 days. So make sure you know all of these teaching. Anxiety is just a feeling of apprehension, fear, or worry. It can occur with or without a cause. So you have in box 27.3, You have symptoms of anxiety types, generalized anxiety. We all probably have felt that. Could interfere with our activities of daily living. If we have it more than 6 months, we have excessive anxiety, we can be considered with generalized anxiety disorder. Panic disorder can be for short periods, panic attacks. I had one time when I went to the Hoover Dam, and I was down up underneath there, and there was a lot of people, and it was a tiled, curved hallway, and we were all crowded in there, and there was one little bitty elevator to get us up. And I looked at my husband and I said, I don't know what you do, but you better get me at the front of the line, because I'm having a panic attack. Never had one in my whole life, haven't had one since, but I guarantee you I had one then. And he's very quiet, but he got me to the front of the line and got me out of there. But it was that impending doom. I don't know, if you've ever had one, you will know you've had it, because it was a strange experience. I was fine when I got out, but whatever it was, it took over me for at least 10 minutes, yeah. That's enough about me. Sorry. Phobic disorder, that's when you have certain fears about objects that can cause a panic attack. Obsessive compulsive. You're trapped in these disturbing thoughts. Like I had a very close friend that was obsessed, and hers came out as washing her hands, and she was just trapped in that, washing her hands over and over and over. Another one I had that I was in college with, and hers was brushing her teeth. I mean, it was constant. You couldn't go anywhere until she brushed her teeth. It was strange. And then, of course, PTSD. We hear so much about that now. And how they work, they're treated with these minor tranquilizers that kind of help sedate the patient and calm them down. Benzodiazepines, one of the popular classifications. Librium, Valium, Ativan, Serax. Those are CNS depressants. And benefit is that they act within about 30 minutes. They can cause dependence. They inhibit the actions of GABA in the brain, which is a neurotransmitter of neurons. They quieten the brain. They decrease the anxiety. Valium has a longer half-life, which makes it a less attractive choice. And beta blockers can also be prescribed for patients with anxiety. And, you know, beta blockers are what are given for blood pressure. But beta blockers, and remember what they do, beta blockers slow the heart rate, make the heartbeat stronger, so they kind of calm everything down. So they're often used for patients with anxiety. The other type is anxiolytic, and that's Bespar, and it's good for chronic anxiety. It binds neuroreceptors for serotonin and dopamine. Remember those two words again, serotonin and dopamine, the two chemicals in the brain that affect so many of these diseases. They increase norepinephrine metabolism to relieve the anxiety, slow the transmission of impulses, and quieten the brain. SSRIs, we've talked about, relieve anxiety by affecting the action of the neurotransmitter serotonin. Beta blockers, we've already talked about. Benzodiazepines bind to the GABA. They end in PAM or AM. Alprazolam, clonazepam, lorazepam, diazepam, etc. So panic disorders, they usually get this Xanax or Klonopin. Anxiety is Ativan or Valium. Insomnia is Restoril or Dalmane. Don't stop these abruptly. You could cause tremors, weakness, seizures, respiratory depression. And if you're given a benzodiazepine, you need to reverse it with romazicon, because it reverses respiratory issues. So this slide. Benzodiazepines can cause respiratory depression, and you need to know where the romazicon is in your facility, whether it's in a crash cart, in a nursing locked bin, or wherever. You need to know where romazicon is. You need to avoid antacids. Remember, Tums we've talked about. They cause a lot of medicines not to be effective. We've talked about grapefruit juice. And I told you before about the physician I knew that did a lot of research, and he said we don't ever need to be drinking or eating grapefruit. And alcohol, certainly, they need to not take because they're at risk for respiratory depression. Antihistamines or other CNS depressants, certainly antihistamines especially, because they can hype you up. And here you are trying to calm down and you're taking antihistamine. And you need to assist them with walking, and they don't need to be driving. Benzodiazepine, GABA is an inhibitory neurotransmitter in the brain. I told you the all in and PAM. Need to watch caffeine. Same thing. Caffeine hypes you up. We talked about respiratory depression. Don't mix it with other meds. Anxiolytics are prescribed now more often because they're less likely to cause dependence. That Valium, Ativan, etc. causes dependence. Used for short-term sleep, sometimes reduces the REM. Used for many things, muscle relaxers, alcohol withdrawal, seizure reduction, anxiety. So you need to take it 1 or 2 hours before or after an antacid. You need to know that. And do not take it, of course, if you're pregnant. Causes drowsiness, dizziness, etc. I can let you read that. Signs of dependence. You have a strong desire or need to continue taking the drug. You're like, okay, I have to have it every night before I go to sleep, or I can't go to sleep. And then you, throughout the years, then instead of a half a pill, you're going to take a whole pill. And the withdrawal effects are irritability, nervousness, trouble sleeping, abdominal cramps, trembling, shaking. Those are, if you have someone who's been taking, let's say, Valium for 20 years. A lot of our older people have. They were put on Valium back in the 70s, and they've been taking it for 30 years. Then when they get to be 90, and you're trying to get them off of some of these meds, or they don't need them anymore, then they start having withdrawals. It's not uncommon. Psychosis is a loss of contact with reality, either briefly or long term. You can have delusions, illusions, or hallucinations. You need to know what all of those are about and see the symptoms in 27.5. I'm looking for that. Symptoms of psychosis: confusion, of course, depression, disorganized thoughts, mania, false beliefs, loss of touch with reality. The friend I had that had Alzheimer's started having delusions that his wife was not there, she was out with someone else, etc. And it was really disturbing for her. So this psychosis, and it can come from when they have Alzheimer's or whatever, they can have delusions, illusions. They start hearing things, hallucinations. They see things, and many drugs cause these, especially the hallucinations. If you've given a patient meds to calm them down or for pain, they may have an allergic reaction, and they may call you in there that they're seeing frogs on the wall or people walking up and down the hall or whatever. So you need to be very attuned to that. Certainly for psychosis, you would offer any kind of treatment, whether behavioral therapy or any drugs or long-term treatment, perhaps, counseling. And all we know is the brain overreacts to neurotransmitters that sometimes causes that psychosis. But hereditary, certainly there are some who have family members that have been dealing with psychosis, and they do inherit it. In box 27.6, potential causes are alcohol, bipolar disorders, brain tumors, certainly, dementia, Alzheimer's, and other brain disorders, epilepsy, depression, schizophrenia, and a stroke can all lead to these psychosis. Antipsychotics block dopamine receptors in the brain. Again, we're talking about that dopamine receptor. And the major tranquilizers that they use for psychosis are Abilify, Thorazine. You'll hear about Thorazine. Risperdal, you'll hear about that. Compazine. Compazine used to be a very popular drug we gave for nausea, vomiting. And because it calms that patient down, now they give other meds usually instead of Compazine. Other drugs you can give, if it's worse, you can give lithium and Navan. Mood stimulizers, they affect the transport of sodium across the cell membrane. The primary use are for bipolar disorders. That's that high, low, and they give that lithium that I mentioned earlier. Now, lithium is a big-time drug, and you have to really monitor it. You need to monitor the level. You need to watch for side effects, seizures, hyponatremia, muscle weakness, tremors, and then they can get toxic on it. And they can have slurred speech and uncoordinated muscles and cause twitching and muscle weakness. Lithium is a big-time drug. It has to be continuously monitored. It's a cation. Remember chapter 1 of health science. It's a cation. It's a positive charged ion. Its pregnancy category is D, so they do not need to be taking it. And I told you about the hand tremors. If they take it long term, they'll develop hand tremors. Schizophrenia is too much dopamine in the body, and we give antipsychotics, Thorazine, Haldol. That's the one I was trying to think of earlier that we give for, used to give for sundowner syndromes was Haldol. But see, it's now given for big-time schizophrenia, and so our little patients would just, that was not a good med to be giving them. You can give it in small doses, but now they give that trazodone and Desiril, and it seems to help better. But Chlorozine, Risperdal, Zyprexa, the danger in giving these is a worsening of the agitation, which is what I saw in the elderly, especially those that we gave that Haldol to. And so they don't really do that anymore. These meds cause hypotension, sedation, seizures. And then this NMS, neuroleptic malignant syndrome, is life-threatening, and it is an increase in body temperature. Please make sure you read about that. Neuroleptic malignant syndrome, and very, very, very dangerous. So Thorazine, Haldol, Risperdal, all of those can kill you. Extrapyramidal side effects, twitching, that sort of thing, you need to know about. Oh, fiddle. Sorry. Okay, antipsychotic meds, I think we've talked about. Positive, they add to normal life. And negative takes away from your normal life. So hallucinations, delusions, disorganized speech are positive antipsychotic states, and a negative depression, lack of motivation, etc. Page 446 is that neuroleptic malignant syndrome that I talked about. And all antipsychotic drugs can cause this, and they can die. And the big one is tardive dyskinesia, and it affects the mouth, the lips, and the tongue, and you'll see patients who are on antipsychotics for a long time, what we call they smack their lips, and they stick their tongue out and kind of smack their mouth with their tongue, and it's very noticeable. So they're having these extra side effects. Acute dystonia is severe muscle spasms of the back, tongue, and neck and face that looks like this. And people who are on these meds can also have that. Akathisia is the inability to rest, relax, difficulty sleeping, pacing, trouble sitting still. And that people are having that side effect, then they're up, they're walking all the time and pacing and fidgeting about all the time. So those are the three big side effects of these antipsychotic meds. We talked about Parkinson, tremors, muscle rigidity, that stooped posture, that shuffling gait. They slide their feet back and forth, and people who've had strokes will do that. They don't pick up their legs. And I told you dopamine is missing. This is the tardive dyskinesia. I didn't remember I had that in there. Unusual face movements, worm-like motions of the tongue, lip smacking. So if you see that happening, you need to notify the doctor. And that's the end of the second half of Unit 5. Thank you.